The current scenario in ART training across the world is of observation only, which although gives you a fair idea of how the procedure is being done, but does not give you the confidence of performing it independently.
I just finished a visit to Indira IVF Group in Udaipur, India. And I'm totally impressed by several things, but one of the things that I'm most impressed of is the way they just prepare themselves for the future and how they're expanding.
My name is Ritesh Agarwal, and I'm head of Academics and Embryology Training at Indira Fertility Academy, a subsidiary of Indira IVF Hospitals Private Limited. So I think Dr. Stephen, he has joined us and we are about to start our today's webinar. I think we are good to go, and just a brief introduction, like every on every third Friday, we are always with you and with another webinar series on embryology topics. So this time it is fertilization failure. Fertilization is the first criteria of tracking embryo development in vitro, a major challenge faced by embryologists while performing conventional IVF is fertilization failure. So today, to talk on this unwelcoming situation and steps to mitigate fertilization failure in IVF cycles, we have with us Dr. Stephen Fleming. Dr. Stephen Fleming is currently Director of Embryology at CooperSurgical and is an Honorary Associate at University of Sydney. He has postdoctoral fellowship from Royal North Shore Hospital, Sydney. He is also known for establishing world's first master's degree program in ART. Dr. Stephen has been a part of numerous books, book chapters, and peer-reviewed journals. Without wasting much of time, let us hear from the expert himself on the causes of fertilization failure, steps to prevent it, and how to tackle such situations. Over to you, Dr. Stephen.
Okay, thank you. So I'll leave my camera off if that's what you want, and I'll share my presentation.
The presentation is visible, Dr. Stephen.
Okay, wonderful. So firstly, I must apologise for having struggled to find the meeting, but nevertheless, I'd like to thank Indira for inviting me to speak in your webinar series on embryology. I've been asked to provide a discussion on fertilization failure, I assume following ICSI. I think ICSI is mainly performed in India, and what options are available now and in the future. So I'll review normal fertilization first of all, because of course it may be that fertilization failure is a result of not being properly trained, not understanding what's required, not using the right equipment, etc. And then I'll go on to consider abnormal and failed fertilization and the application of various remedies such as artificial oocyte activation and rescue ICSI. And then I'll cover the potential of some other ways of improving consistency in fertilization rates, such as piezo and robotic ICSI. So this is really to reduce inter-operator variability. And finally, I'll summarize what's been discussed. So let's begin with reviewing what you should expect. So what normal fertilization means and the importance of training in good technique, including the use of KPIs to assess ongoing competence in ICSI. Following the introduction of the ICSI technique in 1992, two essential steps were identified and published 4 years later in terms of achieving successful fertilization, and these were rupture of the oolemma and injection of an immobilized spermatozoon. And this isn't surprising, since it's necessary for the sperm plasma lemma and oolemma to fuse, allowing delivery of sperm contents into the oocyte to achieve fertilization in vivo. And you can see from this table that if there was no rupture of the ulema and no immobilization of sperm, they were only getting 30% fertilization rates, which is pretty remarkable considering neither of those techniques were applied. If they immobilized the sperm but didn't rupture the ulema, that went up to 37%. And if they ruptured the ulema but didn't immobilize the sperm, that went up to 52%. But it was only when they combined the two that they achieved fertilization rates of 80%. So one of the most key things really is using the right micro tools. So appropriate selection, alignment, and especially the alignment and equilibration of the holding and injection micropipettes is vital to successful ICSI. You can use spiked and non-spiked injection pipettes. They yield similar results, but you have to take more care when using spiked pipettes due to the increased risk of puncturing the ulema on the far side of the oocyte from the point of injection, because that almost certainly will result in oocyte lysis and therefore a failed fertilization of that oocyte. Now, the first and probably the most important step in terms of fertilizing the oocyte in the ICSI process is to select a morphologically normal, progressively motile spermatozoon, then orientate its tail at 90 degrees to the injection pipette. And critically, if the injection pipette has been properly aligned, then its tip will make contact with the bottom of the dish so that the sperm plasma lemma can be easily ruptured. And you'll notice that if you've got like a permanent V shape in the sperm tail. And then the sperm can be aspirated into the pipette. Recommended that you aspirate them tail first to avoid any damage to the sperm head. The second step is to orientate the first polar body well away from the injection pipette, typically somewhere around the 6 or 12 o'clock position. You don't have to be pedantic about this. Anything from 11 o'clock to 1 o'clock or 5 o'clock to 7 o'clock is fine. But most importantly, while gently aspirating the oocyte onto the holding pipette, so you don't want to distort the cytoskeleton of the oocytes. And the pipettes and the ulema should all be in the same focal plane before you propel the sperm to the tip of the injection pipette and slowly push it through the zona and into the balloon-like ulema. The third step is to rupture the ulema by aspirating until there's a sudden influx of ooplasm. And it's important then to immediately equalize the aspiration pressure to minimize the volume of ooplasm aspirated from the oocyte, and then re-inject the ooplasm plus the spermatozoon before slowly retracting the injection pipette and releasing the oocyte from the holding pipette. And here you can see the entire ICSI process from steps 1 to 3. And notice that as you go in, you can judge whether you're going in centrally into the oocyte by that upper image and lower image of the ulema as you go in. So I'll just show you that again so you can see that. So watch for how the membranes appear. One should be directly above the other. So it's important to, there you can see them there. So you want to go in centrally, not off to one side. Now, interestingly, this review of the various factors that are believed to influence clinical outcomes and the quality of lab procedures identified 15 different factors that might influence ICSI outcomes, and some of which I've listed there. So the objective really, when considering the impact of these different factors, is to minimize the cumulative stress that gametes are exposed to during ICSI. So one way of judging when competence is acquired is to use what's called the learning curve cumulative summation, or LCQ-SUM. And that's been used to evaluate training in various ART procedures, including ICSI. In this study, training consisted of performing ICSI using latex microspheres, similar in size to the head of a sperm. And competence was defined as oocyte survival 24 hours after ICSI. And that was achieved after microinjection of 35 to 80 latex microspheres, depending upon the trainee. So different people need different amounts of training to acquire competence. So it's really important you don't rush into doing ICSI too soon, otherwise you will suffer poor fertilization. And indeed, when you look at this inter-operator analysis of KPIs, it reveals a positive correlation between operator experience and ICSI outcomes. And you can see that there's a general trend towards higher fertilization and implantation rates as the number of ICSI cycles increases. So splitting a single cohort of oocytes between 2 or more embryologists is a good quality control measure that you can be used in the event that you're concerned about fertilization rates. So you need a system in place to log lab staff activities and whether they've performed sufficient cycles per month to provide a good reference population. However, it's important to delay or to appreciate that there may be a delay in being able to visualize an effect. Fertilization rates, of course, you know the next day. And besides, the effect may not necessarily be operator dependent. So in an ideal world, you only see poor or failed fertilization because of a patient-specific factor. Now, it's interesting looking at the first ICSI results from the group that introduced it from 1991 to 1995. It's a good example of the value of tracking specific KPIs during training and ongoing competency. And these include the percentage of intact oocytes, the normal fertilization rate, and the 1PN fertilization rates. And in this study, analysis of these indicators clearly showed that it took at least 6 months for the ICSI technique to become perfected in the early days, after which results remain stable. Of course, these days we have the benefit of hindsight and we know what is required to achieve a successful result with ICSI. So the learning curve should be shorter. Now, there can be some issues with sperm that can lead to poor or failed fertilization. So the classic one, of course, is injection of sperm that have no motility. And that may indeed result in poor or failed fertilization, especially if the sperm are dead, as in necrozoospermia. For completely immotile sperm samples, you can test for viability using eosin-nigrosin dye-exclusion staining. And this can be particularly useful with testicular sperm, for example, from surgically recovered aspirates. There may be cases of immotile cilia syndrome, and one of the classic examples of these is cartilaginous syndrome, where the dynein arms in the axoneme are too short for the ratchet-like mechanism that's required for sperm motility. However, usually you can't use sperm staining for the sperm that you're going to inject because it is usually toxic, and therefore you can't use sperm staining for ICSI. But there are alternative methods, and these include the hypoosmotic swelling test or HOS test, which is probably the most familiar with most people. Viable sperm tails swell due to water uptake via osmosis when their plasma lemma is intact. Alternatively, you can use the use of substances to activate sperm motility, and I'll talk a little bit about that in a minute. You can use the so-called mechanical sperm tail flexibility test. This is a bit like the equivalent of rigor mortis in a body. Bodies go stiff, and so do cell membranes go stiff following cell death. So if the sperm tail is flexible when pushed with the micropipette, then there's more likelihood that that sperm, though immotile, is nevertheless viable. And lastly, there's the laser-assisted immotile sperm selection method, where a apparently viable sperm tails will curl their tail when the tip of the tail is subjected to the very shortest pulse of a laser. Of course, bearing in mind that sperm cells are so small, you don't want to be exposing the sperm head to heat from the laser. So for really poor motility samples, we can stimulate sperm motility by using various methylxanthine derivatives. These are phosphodiesterase inhibitors, so they block the breakdown of cyclic AMP and thereby increase the levels of intracellular cyclic AMP, which mediate sperm motility. A range of compounds can be used, including theophylline, caffeine, myoinositol, and 2-deoxyadenosine, though pentoxyphylline is perhaps the most widely used. And you can either use pentoxyphylline at the sort of recommended concentration, where you will get an increase in sperm motility, but the duration of its effect will be limited. If you use that pentoxyphylline, let's say at a 50% concentration, then you extend the duration of its effect. So if you're struggling to find motile sperm, you may want to use it at slightly lower concentration. And what about the oocyte? How do we decide whether the oocyte is maybe the culprit when it comes to poor or failed fertilization? Well, a normal oocyte is a spherical structure enclosed by uniform zona pellucida with uniform translucent ooplasm free of inclusions and a size appropriate polar body. Oocytes undergo both nuclear and cytoplasmic maturation, which are not necessarily synchronous. So in vitro matured oocytes, so taking oocytes that you find at metaphase 1 following oocyte retrieval, and in vitro maturing them to metaphase 2, you can then inject them with the knowledge that they should be haploid cells with extrusion of the first polar body. But unfortunately, most studies show them to have lower fertilization rates than normally metaphase 2 oocytes at the time of oocyte retrieval. So this suggests that if follicles struggle or fail to respond to the trigger for reinitiation of meiosis, then maybe the oocytes are suboptimal in those situations. The Istanbul consensus was that there is actually insufficient evidence for any effect of zona thickness on ICSI outcome. And it was agreed that the presence of inclusions in the perivitelline space is anomalous. So, decide what you like about that. It was also the consensus that oocytes with an abnormally large polar body, as you can see in the upper right hand micrograph, that these should not be inseminated due to the increased risk of oocyte aneuploidy. So these are more likely to be oocytes that have failed to complete oogenesis and therefore essentially are still diploid cells. In fact, these may be 2 diploid cells. You may be unwittingly duped into thinking that the polar body is a polar body. And then there are other appearances like centrally located dark cytoplasm. We often refer to that as a bullseye appearance. That's often related to a negative outcome. But interestingly, those oocytes, as an example of which is the one in the lower left-hand micrograph with a smooth endoplasmic reticulum, you can see a sort of spherical, clearer area. Those ones don't seem to do too badly with ICSI, providing you avoid injecting a sperm into the SCR. So can we relate oocyte quality, for example, to diminished ovarian reserve? Well, this retrospective analysis of the SART data from 2004 to 2011 demonstrated that, in fact, there's no significant difference in fertilization rates between women with only elevated FSH and those with only diminished ovarian reserve, regardless of whether ICSI was used for insemination. So it doesn't seem to be that diminished ovarian reserve is an indicator for a poor fertilization result. One of the common concerns that's often voiced is that fertilization rates may be poor in women of advanced maternal age, since their oocyte quality may be impaired. However, this meta-analysis of 7 studies looking at 8,796 retrieved oocytes, 4,369 inseminated by ICSI, 4,427 by IVF, with a mean female age of 38 years or older, which met the inclusion criteria, showed that there was no significant difference in fertilization rates between ICSI and conventional IVF. So again, suggesting that advanced maternal age isn't really a key indicator for a poor or failed fertilization. And furthermore, subgroup analysis of that data in those patients with 3 or fewer oocytes also demonstrated no significant difference in fertilization rates between ICSI and conventional IVF. Even if only a single oocyte is retrieved, ICSI and IVF produce similar fertilization rates, regardless of whether patients are younger, as in the top table, or older, as in the bottom table, than 39 years of age. And this is in partners with favourable semen quality, of course. Conversely, as you'd expect, in cases with apparent lower semen quality, ICSI does give rise to significantly higher fertilization rates. But these results suggest that in poorly responding patients, even if they only have a single oocyte, it's the semen quality that should remain the most important consideration, and ICSI doesn't necessarily make any difference if the semen quality is good. Having said that, this very recent study from a single centre is quite interesting. They looked at total fertilization failure over a period of time in their centre. So it was a case-controlled study of total fertilization failure, and this occurred in 154 of their couples. And as controls, over the same period of time, they looked at all their patients that didn't experience fertilization failure, so 475 of those couples. These were non-male factor IVF cycles, and there was no significant difference in female and male ages between groups. And in this study, logistic regression analysis that looked at a whole range of variables that they analysed demonstrated that it was only the number of collected oocytes that was significantly related to total fertilization failure, with an odds ratio of -1.37 when there were less than 5 oocytes retrieved. So it does seem to be that it may be something that you need to bear in mind in terms of at least, and this is with IVF, of course, but at least preparing for a poor or failed fertilization if you have less than 5 eggs retrieved. What about checking for fertilization and making sure that we do indeed have a fertilization failure or poor fertilization? So fertilization check, of course, is on the morning following ICSI. A normally fertilized oocyte being defined as having 2 polar bodies. It's important to look for those as well, and 2 pronuclei containing nucleolar precursor bodies. And juxtaposition of the centrally located pronuclei, hopefully of equal size, containing an equal number of nucleolar precursor bodies aligned at that pronuclear junction, has in the past by Lynette Scott and others been correlated with embryo viability. So again, it's another useful thing to look at these variables. So let's now consider abnormal and or failed fertilization and the therapeutic use of artificial oocyte activation and rescue ICSI. So monopronucleate or 1PN oocytes are considered abnormally fertilized. They occur in about 1% of all injected oocytes and may be haploid, as in parthenogenesis, in response presumably to the injection procedure, or they may in fact be diploid, as in asynchronous pronuclear formation. So you may just have missed the appearance of the other pronucleus, or indeed early fusion of pronuclei. However, diploid 1PN oocytes, proven to be so through genomic analysis, have a higher rate of aneuploidy and should be tested to confirm biparental inheritance for that reason. Oocytes possessing 3 or more pronuclei, we always used to consider them as fertilized, but of course they're abnormally fertilized. They occur in about 1% of injected oocytes and may arise due to failure in extrusion of the second polar body, which again is why it's important to look to see whether the second polar body has been extruded. And this may occur following the injection of binucleate spermatozoa or to a failure in cytokinesis. Oocytes that have extruded just a single polar body and that do not possess any pronuclei, we can consider to have failed to fertilize. Fortunately, they normally occur in less than 1% of all injected oocytes and arise due to either sperm or oocyte-related deficiencies in oocyte activation. Low oocyte number and poor gamete quality may be relevant, and rescue ICSI may be possible, but it's important to consider how you use that if that's indeed an opportunity for you. So these are the various combinations that you might see on the day following insemination in terms of pronuclei and polar bodies within oocytes. And they may indicate haploidy, diploidy, triploidy, tetraploidy. Also, you may see early cleavage of injected oocytes at the time of fertilization check, and these may be normally or abnormally fertilized. So in all of these cases, it's probably always worthwhile keeping these abnormal appearances separate from the other injected oocytes and just seeing whether they in fact are able to develop all the way through to producing an apparently normal blastocyst. So as mentioned previously, fertilization failure following ICSI is usually caused by a failure of oocyte activation, which may be due to both sperm and oocyte defects, and it may involve intracellular organelles and metabolic pathways. So of course, these are really rather difficult to investigate. However, artificial oocyte activation may be a remedy since it can increase intracellular calcium signaling. And this, of course, is the way that the oocyte knows that it's been fertilized by the sperm. So there are oocyte activating factors, the classic one being phospholipase C-zeta within the cytosol of the sperm. And when the sperm is injected into the oocyte, they activate second messengers, which cause a release from endogenous stores of calcium within the oocyte, within the endoplasmic reticulum of the oocyte. And you get these characteristic transient pulses or increases of calcium, which are periodic with a certain time in between them, which is characteristic of normal fertilization. So that's the way the oocyte knows it's been fertilized and can respond accordingly via those second messenger systems involving calcium. So the methods or the approaches to mimicking those intracellular transients in calcium are as follows. So application of varying electrical fields to generate pores within the ulemma, which allow influx of extracellular calcium ions. Alternatively, chemical facilitation or activation of calcium transport through calcium channels across the ulemma, and the classic chemicals used for this are strontium chloride and the calcium ionophore A231H7. And lastly, release from intracellular calcium stores by mechanical disruption of the ooplasm. Now, unfortunately, I can't show you this video, but you're probably familiar with it because it's from indoor IVF in India. And essentially, it's quite a dramatic demonstration of repetitive stirring of the ooplasm in an attempt, presumably, to mechanically achieve oocyte activation by a stimulation of those endogenous stores of calcium in the endoplasmic reticulum. And unsurprisingly, there's limited data available to assess its efficacy for improvement of oocyte activation. And indeed, we still require reliable data to assess the relative success of artificial oocyte activation, its greatest utility, of course, having been demonstrated in patients with total fertilization failure or very poor fertilization rates, so typically less than 30%. But fortunately, the small numbers of children born so far following artificial oocyte activation suggest that it is safe, but there's always the risk that it may affect downstream gene expression, because of course these increases in calcium that are achieved artificially are not the same as those transients in calcium that occur at normal fertilization. So we're not sure whether trying to mimic them is going to be without any consequence. Now, the other possibility, if you're confronted with a failed fertilization, is, of course, rescue ICSI. And we used to perform this in the early days, back in the early 90s. And of course, we always used to perform it when, in my view, it was way too late. We'd do the fertilization check the following day, and we'd try rescue ICSI, and usually it wasn't much good because, of course, by then the oocyte is post-mature and refractory to activation by the sperm. So, the sperm may be fine, but you're not going to activate the oocyte that late on. So it's performed these days either following failure of second polar body extrusion on day 0, the day of egg retrieval. So, for example, in China, this is a fairly common practice because there's a heavy restriction on the percentage of patients that they're allowed to do ICSI with. I think it's around 25% or whatever. So what they do as a failure proof device, I suppose, is they actually check the oocytes 4 hours after insemination in those cases where they're obliged to do IVF. And if they see no extrusion of the second polar body 4 hours following insemination in all the oocytes, then they go in a timely manner and do rescue ICSI. I'm sure they get better results by doing that. Of course, you can do rescue ICSI following failed fertilization on day 1, and rescue ICSI per se can result in the delivery of healthy neonates, though you have to accept that the pregnancy rates are going to be low. And the clinical evidence doesn't indicate an elevated rate of malformations, which is, quite nice, really, that that's the case, because, of course, you're always concerned when you're injecting eggs late on, although the data are limited and incomplete. So do we have any other avenues available to us or in future where hopefully we can reduce failed fertilization, for example, in women with fragile oocytes, let's say, where you get more degeneration of oocytes than fertilization of oocytes, and maybe just as importantly, whereby we can reduce inter-operator variability. And in this respect, piezo and robotic ICSI appear to have the most potential. So piezo-assisted ICSI, very popular in Japan, is a procedure that uses an innovative tool with a very high-speed movement of the injection micropipette caused by the piezoelectric elements within the piezo injector. And in one study, piezo ICSI showed significantly more favorable results than conventional ICSI, with a survival rate of 97%, so that's nice and high, versus 94%, and a fertilization rate of 83.5% versus 70.6%. However, if you do fertilize the oocyte, what they found was that there were no differences in blastocyst development, implantation, miscarriage, and live birth rates, or congenital abnormalities. So again, reassuring that if you use piezo ICSI, it's safe to do so. This is, an image which, again, I can't share with you. Unfortunately, I have a block on sharing these images from YouTube, but I'll show you something similar a bit later. Other alternatives are to use various automated techniques, and we know that some of these have been introduced using microfluidics, for example, for denudation of oocytes and selection of sperm for ICSI. But robotics are really interesting because they're being investigated for sperm tracking and immobilization using a motorized rotational microscope stage combined with a servo control. And there are other techniques to validate whether an oocyte, for example, has been successfully injected. So real-time measurement of electrical resistance of the ulema to confirm fertilization. And as I said previously, robotic orientation and clamping of the oocyte in the right position relative to the first polar body for injection. And artificial intelligence is becoming really important in this respect. As I'm sure you know, it's an umbrella term for the use of algorithms and machine learning or deep learning. And in this respect, convoluted neural networks are deep neural networks specialized for analyzing visual images. So as such, they've been used for sperm and oocyte analysis for both sperm selection and immobilization, and to identify the optimal injection site on the oocyte. In this study, 383 individual spermatozoa were retrospectively analyzed from a data set of 78 randomly recorded ICSI-assisted reproductive technology cycles. They used so-called SID software to compute the progressive motility parameters of each sperm trajectory, along with a quantitative value, the head movement pattern. And what they found was that the linearity of the curvilinear path and sperm head movement pattern were found to be significantly different between successful and unsuccessful fertilization, with a p-value of 0.038 and 0.029 respectively. So this is a video example of the automated injection process. So this is using piezo injection to show you what it's like with a human sperm and oocyte. So the automated system scans the oocyte so that it can be segmented and analyzed by AI algorithms. Then it aligns both the holding and the injection needles at the equatorial plane of the oocyte. Afterwards, the injection needle, the piezo injection pipette, is advanced towards the oocyte, and the AI algorithm instructs the activation of piezo pulses to perforate the zona pellucida. And the number of pulses needed to perforate the zona pellucida depends upon its thickness, which is detected based on the segmentation performed previously in the oocyte by the AI algorithm. After drilling the zona pellucida, the injection needle is retracted so that the small piece or zona pellucida cork created as a result of the application of the piezo pulses can be expelled manually outside the oocyte. Next, the sperm is brought to the tip of the pipette manually, and the pipette is advanced again automatically through the hole created previously in the zona pellucida and pushed against the ulema up to 75% of the diameter of the oocyte. At this point, AI algorithms instruct the system to activate a single piezo pulse to break the ulema so that the sperm can be released manually inside the oocyte and the pipette is then carefully withdrawn automatically. So the injection process is performed almost entirely automatically, except for the control of the sperm inside the microinjection pipette, which still requires manual control. And in this first report of live births using automated ICSI, they initially did some preclinical trials on mouse, rabbit, hamster, and human oocytes, which demonstrated comparable data between automated ICSI and standard ICSI. And then they looked at clinical data using human donor oocytes. And with the automated ICSI, 13 of 14 oocytes injected, fertilized, versus 16 of 18 oocytes injected by standard ICSI. And 8 of those 13 zygotes created by automated ICSI developed into good quality blastocysts, versus 12 of the zygotes achieved via standard ICSI. 4 of those 8 blastocysts created via automated ICSI were euploid, and following the transfer of 3 of them into a couple of patients, it resulted in 2 live births. And this was in comparison to 10 out of 12 of the standard ICSI blastocysts, which were euploid. So maybe some room for improvement there in terms of blastocyst development and euploidy. So convoluted neural networks have been applied to real-time analysis of sperm kinematics to identify sperm most suitable for ICSI. And in this pilot study with computer-assisted analysis of those 383 sperm from 78 ICSI cycles, you can see that linearity of the curvilinear path and the head movement pattern were both positively associated with the fertilization rate. So that's just the sperm data from that previous study. So in summary, ICSI is a high precision technique requiring proper training, ongoing competency assessment, and high quality equipment and consumables. To get good fertilization, you need stress-free preparation and selection of gametes, certainly desirable. And if you are faced with hopefully just patient-specific poor fertilization or failed fertilization, then techniques such as artificial oocyte activation may overcome fertilization failure. And an example of this, of course, is the use of globozoospermic sperm, devoid of their ecosome, where they seem to benefit in terms of fertilization following ICSI, if it's combined with artificial oocyte activation. And in terms of the future, what we may improve, piezo ICSI and robotics and AI, I think are quite likely to improve the consistency of good fertilization rates in the future. So I hope that was of some benefit to you. It's a sort of broad subject with probably relatively few remedies in terms of what we can do about it.
Thank you, Dr. Stephen, for such a nice and elaborative talk on this yet another such a sensitive issue, the absolute fertilization failure. Actually, whenever I think of this topic, absolute fertilization failure, it really reminds me of long back when I used to do IVF only cycles. So I think that was more common with the IVF, and by now, since we have switched to ICSI more precisely, and with ICSI, I have witnessed less situations, this type of distressing situations. It was more common with IVF, probably because of some maybe zona binding or some antibodies, anti-sperm antibodies, or maybe because of that. It was more common. But yet you have covered maximum, like you have covered all the aspects, even with the ICSI, what are the do's and don'ts of doing it the correct way of doing it, the rescue ICSI and everything. Now I think the forum is open for any questions. If you have any questions, all the doctors, because I think doctors, they are very scared of this thing.
Indeed.
Especially the doctors, because
they're the ones that have
become
to go and speak to the
speechless.
patients often.
Yeah, they become speechless. What to tell people, what to answer to the couple, because they are really looking forward for the number of they look forward for how many embryos are formed and how to tell them that there is absolutely no embryo. And Dr. Stephen, out of your experience, or maybe your as per any study, recent study, how effective is this rescue ICSI?
How effective is what? Sorry,
Rescue ICSI.
Rescue ICSI. Well, I'm really looking forward to seeing the data come out of China, because, as I said, we were always compromised in the early days when we attempted rescue ICSI. We either got no fertilization, or if we were lucky, very poor fertilization. So, you know, certainly in those days, it was very unsuccessful. And I think, you know, for safety reasons, because you could not be sure, for example, that a sperm wasn't in the oocyte and going to contribute to the genetic makeup of the oocyte. It was, for example, banned in the UK, which is when we were using rescue ICSI. But I think it's really interesting what they're doing in China, because, as you rightly said, if an egg isn't fertilized following IVF, then in all likelihood, a sperm hasn't managed to penetrate and activate the oocyte. So I think in that case, you know, they're probably on safer ground, and most importantly, they're more likely to get some encouraging results with rescue ICSI if they go in and do ICSI, you know, especially if they, for example, did an insemination, let's say early in the afternoon, let's say 2 o'clock in the afternoon, did their IVF insemination, checked for extrusion of the second polar body, let's say at 6 o'clock in the evening, didn't see any extrusion of the second polar body in all the oocytes they inseminated, then they go in and do their rescue ICSI. I think in that scenario, they're probably going to get results which are not far off what you'd get if you'd done ICSI in the first place. So I think in that scenario, it's encouraging. I think rescue ICSI following ICSI, I'm not expecting, you know, maybe very good results. And there's always that confusion, you know, are you injecting with rescue ICSI and an ICSI oocyte because the sperm never got into the oocyte? It was left in the perivitline space, so you hadn't actually ruptured the oolemma properly, or for some other reason. So it's a bit more problematic, I think, following ICSI, but certainly following IVF. Like I say, I'm fascinated to see the data when it eventually starts coming out of China.
Just a continuation of the same question. So what is the exact method of doing rescue ICSI? So do we do the oocyte activation along with the rescue ICSI? And if yeah, what is the exact method? How do we do the rescue?
Well, that's a really good question. Because I think the early failures with rescue ICSI, I suspect, was because, as I said in the presentation, that you know, once the follicle sees the trigger injection for reinitiation of meiosis, the clock is ticking. So time is not on your side. You have to inseminate those oocytes in a timely manner relative to when you administered the trigger injection. And so the longer after that optimal time for insemination that you leave the oocyte is losing its ability to respond to the activation by the sperm, and therefore losing the ability to become fertilized. So I think if you're faced with a considerable or a significant period of time following your initial insemination, then it makes complete sense to me to combine rescue ICSI with artificial oocyte activation, because that's what the oocyte is unable or becoming less able to do as it ages. And we know, you know, pretty much 24 hours after retrieving a mature oocyte, it's too late. It's way too late. So yeah, I agree with you. It's a really good question, a really interesting one. And again, I haven't seen much published combining the two, if anything. I can't think of much, but that would, to my mind, that would make the most sense.
So basically, it's like a chance that within 24 hours, of in case there is heart failure, right? So one can think of combining rescue XC with artificial oocyte activation and then go ahead.
Well, that's, yeah, I mean, who knows how well it will work, but I think that's what you'd be obliged to do if you're going to do it on day 1 rather than day 0. So I think come day 1, if you did your ICSI sometime between, let's say, 2 and 4 in the afternoon, which is typical, or your IVF, between those times, then come day 1, that's pretty late. So I suspect the reason that we had the poor results was we weren't doing artificial activation of the oocyte, and it would make sense to combine the two if you want to get fertilization of the oocyte.
Okay, but ideally it should be as quickly as possible.
Yeah, time, you know, as my grandfather always used to say, he'd ask me, how's the enemy? And by the enemy, he meant what time is it? So time is the enemy with anything to do with a maturing oocyte. So, and that's why IVM works pretty well. You know, you go in early and, you know, you can do what you need to do. But going in late or leaving, you know, your stimulation too long, doing your oocyte retrieval too late, and then expecting similar results to a more timely retrieval of oocytes, you're going to start running into problems. And I think, you know, rescue ICSI is a classic demonstration of the refractoriness of the oocyte to being fertilized as time progresses.
Whether we can take the questions. So I think there are a few questions in the chat box.
Yes.
Okay.
So yeah, so I'll read those one by one.
Oh yeah, I've got some in the chat. Do you want me to answer these in the chat?
Yeah. So the first question here is, many centers have a trend to inject all the oocytes that they recover, irrespective of its immaturity. Now, we know that it's ethically wrong, but should we inject a diploid oocyte also? Have you ever seen that? I think by diploid oocyte, they're meant to say a giant oocyte.
Yeah. It's always difficult to say whether something is ethically wrong. I would say it's scientifically wrong because, you know, you don't know that the egg still has a diploid set of chromosomes until you've seen extrusion of the first polar body. So I would say that it's not good practice. It's not good scientific practice to inject all the oocytes. Thankfully, in my working life, I've not witnessed that. What you tend to find is that if the oocytes are the germinal vesicle stage at recovery, they're never going to make it to metaphase 2. You know, there's just too much of a gap for them, and they obviously haven't responded at all to the trigger injection. But if they're at metaphase 1, and you want, you know, especially if you're struggling for oocytes, then by all means, it seems reasonable to me, ethically reasonable to me, certainly, and scientifically, you know, acceptable to allow that metaphase or those metaphase 1 oocytes to in vitro mature to metaphase 2 and then inject them, but always keep them separate from the oocytes that, you know, were as you expected at metaphase 2 at egg retrieval. So that would be my approach, because you always want to be choosing the embryo that develops from the ideal oocyte before you choose, if you like, the second choice oocytes, the ones that matured late. Do you want me to do the next one, which is more efficient? Piezo ICSI.
Yeah. So the next question would be: are there any specific genetic?
Which one is more efficient? Piezo ICSI or standard ICSI?
Oh yeah, I've got it. Yeah. Are there any specific genetic or epigenetic markers associated with oocytes that are more amenable to rescue ICSI? That's a tough scientific question. Well, if the problem's due to the oocyte, so we know that there are individuals, for example, that have low levels or no oocyte activating factors within the sperm cytosol. So you can look for levels of phospholipase C zeta within the sperm cytosol. So they're definitely markers for sperm that might be a problem with oocytes that are going to end up being more amenable to rescue ICSI, but are actually probably more amenable to artificial oocyte activation. So in terms of oocytes more amenable to rescue ICSI, well, if there are, and again, I've not really, been up to date with that particular area of research, but if they are, it's going to be involved with those second messenger pathways, from the receptor to PLC zeta, through to IP3 and activation of intracellular calcium. So it's going to be somewhere in that cascade. So it may be that oocytes, for genetic reasons, either fail to have some components of that calcium release cascade in place, or they're failing or blocking for some other reason. So yes, for sure, if you could identify patients with markers for those kind of defects, then again, I wouldn't say more amenable to rescue ICSI, but more amenable to artificial oocyte activation. I think with rescue ICSI, it's really tough. I mean, rescue ICSI is really a procedure rather than a defect. So rescue ICSI is something that you attempt to do. And as we discussed earlier, in certain situations, depending on when you do the rescue ICSI, it makes more sense to combine it with artificial oocyte activation anyway. So yeah, so if there are any genetic or epigenetic markers, they're going to be present either within the sperm cytosol, because you don't worry about anything on the sperm plasma lemma with ICSI, or within the ooplasm of the oocyte. I just don't think there's been much on this at all. But it's, again, a really interesting question, because if we could, predict those patients, if they had, I mean, these are probably, again, they're going to be gamete specific. So you're going to have to collect some sperm samples at least and check those. And you'd have to go through some kind of oocyte retrieval to check them for the oocyte. So it's problematic, really.
True. Plus, it's also not always feasible to, go for checking those markers and coming back and then thinking which way to proceed and how to proceed about it. That is also one thing. In general, routine embryology labs, we don't go around looking for markers or anything, right? We just have to make a decision right then and there. That's another thing.
Yeah, I think it's really important. I mean, we always used to meet up with the couple once we knew how many eggs we'd collected, and once we'd done the sperm prep, we knew, what the quality of the sperm was, and we'd always engage them in the understanding of the decision making over what we were going to do. And typically we would either do routine IVF, or we'd split the sample between IVF and ICSI, or we'd do ICSI. And regardless of what the decision that we reached with them was, we always forewarned them that there was no guarantee, because even with ICSI, there's no guarantee that you're going to get fertilization, because there are, as I described before, there's about 15 different variables that might impact the relative success of ICSI. So I think, patients are always going to be disappointed, of course, if they get a poor result the following day, but at least if you've prepared them for it and you counseled them for it and involved them in the decision making, it's hopefully less of a blow, and it's easier then to move on to maybe offering them a better approach in the next cycle. And that may come down to nothing to do with your ICSI. It may come down to changing the ovarian stimulation, for example.
Kind of in the similar footsteps, there's another question that says, how would you know the cause of fertilization failure is due to the oocyte or is it due to the sperm?
Yep, so that's a good question. And as you know, as I sort of explained during the section on artificial oocyte activation, it's very difficult to identify where the source of the problem is coming from. So again, in the old days, we used to, if we, had an issue with fertilization, whether it was poor fertilization or failed fertilization, we sometimes used to suggest to couples that maybe they would like to try splitting a proportion of their eggs with donor sperm. So that way we could at least, in a in vitro clinical situation at least, rule out whether it was a sperm problem or not. So, of course, we'd expect the donor sperm to fertilize the oocyte perfectly well. And if there was an ongoing problem with the partner sperm, then, we should see a differential between the fertilization rate with the donor and the partner sperm. If it comes down to an oocyte problem, then I guess you could do it the other way around. You could, suggest that we look at some donated oocytes and use them as a control group. You probably only need maybe 3 oocytes, which you inject with the partner sperm as a test to see whether it's an oocyte or a sperm-derived problem. So those are the only clinical ways. And again, if you want to do it preclinically, then again, you need to look more in depth at the sperm and the oocytes in the way I was suggesting earlier in terms of activating factors and the ability to respond to the sperm activation.
Now I have a question of my own here.
Okay.
You talked about artificial oocyte activations, right?
Yes.
I just want to know, how would we decide, beforehand, if I want to go with AOA for a certain case? Like, is there any indication that allows us to choose that I have to decide that, yeah, this is my course of action, I'll be moving on with artificial oocyte activation? Is there any indication for any such case, or do we do it only after we see a failure?
Okay, so, well, as I said earlier, the classic one is if you have sperm where previously it's been demonstrated that they have problems activating the oocyte, and the classic example is that of globozoospermia. So with globozoospermia, you tend not to get such good fertilization rates if you do standard ICSI. So that would be a flag or an indicator, for example, to go straight ahead and do artificial oocyte activation in combination with your ICSI. Other than that, it's a bit difficult to think of, other factors. I mean, unfortunately, in most instances, it's a sort of, a retrospective decision. So unfortunately, you discover that there's a problem with the initial cycle, and then to try and prevent, just a repeat of that problem, then you maybe would consider using artificial oocyte activation. But there aren't really, and again, we kind of addressed this before in terms of the epigenetic and genetic markers. It's very difficult to look visually at a sperm cell or a oocyte and say, well, that's going to need artificial oocyte activation, because there aren't really any morphological factors on the surface or even within the cytoplasm that we can identify that indicate resorting to artificial oocyte activation. So all of those oocyte anomalies I sort of spoke about, I mean, I can't think of any of those that are being related, for example, to inability to be activated. They tend to be maybe other issues. It's just sometimes oocytes can't fertilize or don't fertilize because of it may be ultrastructural problems. It may be that they don't have the cytoskeletal structure to be able to form pronuclei and go on from there. So it may be nothing to do with the activation of the oocyte itself, but other components of the oocyte that are suboptimal. But again, I can't think of any published work that identifies such oocytes prior to experience. So it's a tough question, that one. Tough one to answer.
Okay.
It'd be nice if maybe with AI in future, it'll be so amazing at identifying oocytes. Maybe if we're lucky, we'll start, getting some useful information from AI, from morphometrics of sperm and oocytes to identify these effectively defective gametes that may require activation help. So, but at the moment, I can't think of anything that has been revolutionary in that respect so far.
Very true. So eventually, it is the AI which is going to take over the charge of deciding what to do and what is the final consequences of any particular oocyte or any particular sperm. So what should be the fate of an oocyte and how to do the procedure?
Yeah, I'm sure it will. I'm sure it'll grade. I've seen some amazing devices that use AI to identify the sperm that are most likely to fertilize the oocyte and more importantly, produce a good quality blastocyst. And they automatically pick them up, put them in your sperm drop, ready for you to go and do ICSIs. That's just phenomenal, really. Imagine the time that saves, especially with some difficult sperm preps. So that alone, I think, anything that assists us be more efficient in what we're doing would be a great boon. And maybe the same will be true of oocytes, that we'll really be grading embryos at the oocyte stage with the help of AI, and we'll know which of the oocytes is going to form the best blastocyst even before we've inseminated it.
So you must take the next question.
Yes, we have 2 more questions.
Okay.
There's one interesting question. They have asked, what could be the main cause for reverse cleavage in oocytes?
This is in donor oocytes, so okay. Well, I don't think we know, to be honest. It's essentially, it's obviously a failure of cytokinesis. So, normally the spindle of the oocyte will migrate to the center of the oocyte, and you'll get cytokinesis, 2 equal cells, a 2-cell embryo, and that should happen repeatedly, so that you get hopefully relatively synchronous division of those 2 cells and so on and so forth to form a 4-cell embryo and so on. But if you get reverse cleavage, that suggests a failure of cytokinesis. So perhaps what is happening is that the cell's trying to divide and then maybe flops back into what it was before, and maybe somehow there's incorporation of other cell membranes in that. So I think what you're really talking about is going to 2 or more cells and going back to 1 cell, or less than let's say less than 3 cells or 4 cells, whatever. So I guess it's an incomplete cytokinesis, effectively. So it may appear that the zygote, for example, has cleaved to form 2 cells, but in terms of the completion of that process, it clearly hasn't occurred, because otherwise, why would those two apparently independent cells coalesce and go back into a single cell again? So yeah, so that's, I mean, that's interesting, because again, that demonstrates that there are other aspects of failed activation of the oocyte that don't necessarily involve those calcium transients. It may involve, defects in the cytoskeleton. So that's pretty interesting. Hopefully it doesn't happen iatrogenically. So hopefully it doesn't happen because you haven't maintained the correct temperature in your ICSI dish or in your culture dish following ICSI. So we know that, once the temperature of oocytes, or the temperature of the media that the oocytes are in, drops below 35 degrees, you start getting depolymerization of the microtubules making up the cytoskeleton. So again, it could be iatrogenic, so just not maintaining the proper conditions, especially temperature, which in itself will affect pH as well. So it could be, that could be a cause, but you assume that most of them are due to cytoskeletal issues, because often it's only in a few of the embryos of a cohort. So if it was a problem with culture conditions, for example, or handling, then you'd expect to see it happen in a significant number of those zygotes and those embryos.
Yes, so in such cases, it's better to check at the culture conditions first. And if everything is all right, then we can assume that maybe the inside quality as well and improper cytokinesis is happening. Right?
Yeah, I think you're right. I think most of the damage that we do unwittingly is at the oocyte stage, because especially when you consider with ICSI, we're doing so many procedures outside of the incubator. We're using an invasive procedure. We're stripping off the cumulus cells that help maintain the intracellular pH of the oocyte. So we're not doing the oocyte many favors during an ICSI procedure. So we have to take extra care of those environmental and culture conditions when we do ICSI. So I think you're quite right, and that begins with denudation of the oocyte. So we need to be really mindful of how gently we're handling these oocytes, how we're controlling those variables, and how quickly we perform the procedures, get them back into the incubator.
Yes. Now, the next question is, can stimulation lead to multiple polar bodies in oocytes? Is there any correlation between stimulation and multiple polar bodies in oocytes?
Yeah, not to my knowledge. Not denudation. I mean, don't forget that multiple polar bodies is not necessarily abnormal. So what we've got is an oocyte that's undergone that first meiotic division to produce that first polar body and the oocyte. The oocyte then undergoes the second meiotic division in response to activation by the sperm and extrudes the second polar body. But that first polar body can respond in the same way as the oocyte and divide. So having three polar bodies is not necessarily an abnormal phenomenon. It can be a natural phenomenon that you sometimes see. So I wouldn't be that concerned if you've got three polar bodies, because after all, the polar body sitting there just like the oocyte, probably going to want to respond in a similar manner. But in any case, those polar bodies degenerate fairly soon after cleavage begins anyway. So I don't think it's a problem, and I don't think it's due to stimulation.
Following the same question, there's another question now. Are oocyte dysmorphisms related to stimulation, or is it inherent due to patient factor?
Well, both is the answer. So some dysmorphisms are related to stimulation. So, if we see issues, for example, if you saw urplasm that was consistent with post-mature oocytes, then I think it's reasonable to accept that probably is related to stimulation. And it may be that other dysmorphisms are stimulation related as well. I think when you see severe morphologies or severe dysmorphisms, they're probably more related either to variability within a patient or to something that's patient specific. So, we have to remember that in an ideal world, we would have that one oocyte that we would retrieve from that one follicle that's mature. In the artificial world, we're stimulating a whole cohort of these follicles, and we're maybe unreasonably expecting that all the oocytes coming out of those follicles are going to be equivalent. And of course, they're not. They come from different sized follicles. They come from follicles with different vascularization, maybe different oxygen concentrations. All these sort of variables between follicles are going to have a knock-on effect on the oocyte. So I think that it's that. So you could say that in itself is stimulation dependent, because we're trying to prevent these others from undergoing the normal atrophy that they would normally undergo, atresia and atrophy, and we're trying to keep them going. So maybe some of the dysmorphisms we see are from those few follicles that we maybe shouldn't have rescued or kept going and retrieved oocytes from. But other dysmorphisms, I think, like I said, the severe ones, I suspect, maybe due to patient factors. So, the very large polar body, for example, I mean, that's fairly abnormal. That's maybe indicative of a defect in oogenesis itself, rather than maturation of the oocyte.
Okay, thank you.
I think whether we can take the last question. So just recently one question has popped up. Sir, how do we rule out if it's the lack of cytoplasmic maturation of oocyte that has caused poor fertilization?
Very important question. Very good question. So unfortunately, as embryologists, we learn that an oocyte is mature if it's extruded its first polar body. But we know from IVM now that there's a big difference between whether an oocyte is cytoplasmic mature or not, whether it's achieved that. So, I guess if we see nuclear maturation, so we see extrusion of the first polar body, then I guess we can at least rule that out, and we can say, well, the oocyte has undergone nuclear maturation, so it should be good in terms of its genetic composition. However, if it's if the oocyte has failed to fertilize, or there's poor fertilization, and it's nothing to do with nuclear maturation, in fact, it's probably always more likely to be due to cytoplasmic maturation, because again, the oocyte, as it's growing and maturing, it's developing all of those proteins necessary to be able to respond to the sperm at fertilization. So I think we can't rule that out, that it's an issue with cytoplasmic maturation if we see that phenomenon. I suppose the only way we can rule it out is by checking that it's not something to do with the sperm or the technique, or environmental factors. So I think it's a really important question, and it just says to me that we need to learn a lot more about egg maturation, and maybe as we do more and more IVM, we'll get a better handle on this and understand better. You know, for example, we know that IVM fertilization rates following IVM are pretty damn good, maybe not quite as good as IVF, but maybe that's going to be the model that tells us whether we can identify or rule out an issue with cytoplasmic maturation in these oocytes following ICSI, whether they fertilize or not. So again, it's a really good question, difficult one to answer, but I think there's an opportunity with IVM to maybe learn a bit more about it. Is that a good place to finish? I'm you know, promoting IVM, I know, but you know, we need to use all the techniques at our disposal to learn as much as we can about how these gametes are really behaving, because there's still more questions than answers, I think.
Right. So the questions they are never ending, because the curiosity in an embryologist that never ends to ask questions, or especially when it comes to fertilization failure, such a distressing topic and such a horrifying topic, I would say rather. Thank you, Dr. Stevens, for such an enlightening and informative talk on this sensitive topic. And I really thank CooperSurgical India team for connecting with you, for helping us to have this webinar happen. So just for the information's sake, that this webinar is one of its kind. Like it happens. This is a part of international webinars which happens every month. It happens on third Friday of every month, where the speakers from the entire globe, they come and they contribute their experiences, they share their experiences, they speak on some topic, and then they are this is how the Indira Fertility Academy, which is a subsidiary of Indira IVF Hospitals Private Limited. It's an initiative by IFA to contribute in the academic development of the embryologists as well as the clinicians, ART clinicians. So at IFA, we are having short-term as well as long-term courses for both for embryologists as well as for the clinicians, ART reproductive, who want to pursue their career in ART and ART treatments. So thank you again, Dr. Steven. Thank you very much for
more than welcome.
Your time.
And thank you for inviting me along.
Yeah.
Great. Thanks again.
Thank you.
And good luck with the future webinars in the series.
Thank you so much. Thank you.
Okay. Bye then.
Bye bye.